Hello. I'm excited to welcome you to our session today, Breaking Barriers and Bridging Gaps, Global Strategies for Implementing Innovations for Alzheimer's Accurate Diagnosis. This is the sixth meeting of the Davos Alzheimer's Collaborative System Preparedness Learning Laboratory. We're excited to be joined by participants from over 42 countries representing 200 organizations. DAC intends to work globally to address some of the greatest challenges in Alzheimer's disease research, treatment, and care, and today's audience reflects our endeavor for a global reach. My name is Dr. Tim McLeod. I'm the director of the DAC Healthcare Systems Preparedness Program. I'm very excited to welcome you to today's discussion and very excited for you to meet the great lineup of experts and panelists that we've got for you today. So the purpose of the meeting is to bring together experts in the detection and diagnosis of Alzheimer's disease and related to dementia to discuss what we've learned and where we need to go to ensure healthcare systems are prepared and equipped to address the growing challenges we face. Our goal with the System Preparedness Program is to run implementation studies in the real world that uncover barriers and facilitators to system preparedness. Our unique implementation science approach means that we pull data and insights in near real time, and that the goal of our studies is not only evidence generation, but knowledge translation. The meeting today is a key part of our strategy to make sure research and insights from health systems around the world are shared quickly to achieve a comprehensive global strategy for timely diagnosis. Through our Learning Lab discussions, we hope to work together to identify ways to both reduce barriers and increase access of new and innovative tools so that all healthcare systems around the world can use them. This is the sixth meeting of the DAC Healthcare System Preparedness Learning Lab. We began in 2021, which feels very recent, but it's great to see this is the sixth time we're doing this. Our initial focus was on early detection of cognitive impairment, and we're excited as we move into our next phase of efforts, focusing on accurate diagnosis of Alzheimer's disease and related dementias across low, middle, and high resource settings. So the dialogue today is meant to be interactive, so I would encourage you as you're following along, if you've got questions from our panelists, you will notice a Q&A function at the bottom of your screen that has sort of two speech bubbles. So we will monitor that chat and do our best to triage those questions to panelists. So please ask away. So I'd love to kick off our meeting today by welcoming Dr. Suzanne Schindler from the University of Washington to join me for a fireside chat. Dr. Schindler is a clinical neurologist and neuroscientist focused on improving the diagnosis and treatment of Alzheimer's disease. She currently sees patients with memory concerns, coordinates biomarker testing for the Washington University Memory Diagnostic Center, and leads the Fluid Biomarker Core for the Knight Alzheimer's Disease Research Center. She's a core member of the Global CEO Initiative on Alzheimer's Disease Blood Biomarker Work Group, leading a work stream with the purpose of defining use cases for blood-based biomarkers for symptomatic patients and defining ideal minimum test specifications. On top of that, Dr. Schindler both sees patients, really understands the science of these tests, and can translate that to sort of real terms and very practically. So Suzanne, thank you so much for joining me today. I'm really looking forward to our conversation.
Thanks so much for inviting me, Tim.
So I thought we would break our time sort of into three chunks. So I'd love to just talk about current practice, and then we can talk about what the world looks like near term in translating research to practice, and then end with, what we can do near term collaboratively. So just so we've got sort of a shared mental model, could you start by just giving us a quick overview of the key steps in an Alzheimer's diagnosis today and tell us about some of the big bottlenecks in that pathway?
Certainly. So imagine that a patient develops some problems with their memory. So maybe they start repeating information, misplacing items frequently, forgetting about appointments, forgetting about details of events. The first thing that has to happen is that someone has to notice this. Sometimes that's a patient, more often it's a family member. And that first step is actually, I think, the largest bottleneck. A lot of people think that cognitive decline and memory problems are normal with age, they're actually not in many cases. And so this can really delay them going to see a doctor. So then they have to go present to usually a primary care physician first. And the primary care physician has to take it seriously and do a workup that includes cognitive testing, routine blood work, structural brain imaging, and then in some cases, there's a referral to a dementia specialist. And unfortunately, dementia specialists are in high demand. And so it could take 6 months to a year to get in to see a dementia specialist. Once you do get in to see a dementia specialist, we are usually able to work up people pretty quickly, although in some cases there are limits to our abilities to do specific biomarker tests like amyloid PET or CSF tests or even blood tests. So there's quite a few bottlenecks and steps along the way, and this means that it can take many months to even years from the time that people first develop symptoms to the time that they have a diagnosis.
Great. And so again, some of those big bottlenecks where, there's obvious opportunities to streamline and speed things up. Could you just give us, a broad overview of some of the novel diagnostic tools that are either here or coming soon, that may, hold a key to solving some of those challenges?
Well, as I mentioned, one issue is just recognizing a problem and also for primary care docs to take this seriously when patients present with this. So there are a number of digital cognitive assessment tests that are being developed. There are actually quite a few. And I think those are useful because primary care docs don't necessarily know how to do these sort of evaluations. And it may be difficult to do these efficiently without tools like digital cognitive assessment. So I think those can be quite helpful in recognizing there's a problem. And then the second major tool is blood tests. So we now have quite accurate blood tests. There's a variety of different blood tests. Some are accurate and some are not, but we do have accurate blood tests that we can use to determine whether the cause of cognitive impairment is likely to be Alzheimer's disease or something else.
Right. And in the context of the sort of care pathway you described and the real challenge of getting someone from awareness that they may have a cognitive issue to see a specialist, obviously that's fairly challenging. What is sort of the promise of blood in helping with that chain?
Well, blood tests are a modality that primary care docs often use. So it would be possible for a primary care doctor to order a blood test and interpret it. That's not really possible for things like amyloid PET scans and CSF tests that only dementia specialists typically use. So I think blood tests really could bring that level of, help, diagnosis to primary care, which is exciting.
Yeah. I mean, blood is a really interesting example where you've got a novel diagnostic that's starting to make the jump from sort of research use only or, used in controlled research settings to sort of routine clinical practice. And so as that happened, how can we ensure that these innovations are both accurate and also very practical for adoption by care providers?
So we've been using Alzheimer's disease blood tests at Washington University for about 3 years. So we've gotten to feel comfortable with this, and we also have been involved in the development of these tests. So we know, which ones to use. But there's, as I mentioned, quite a few different blood tests out there. And so it's challenging for providers to know which ones are accurate, which ones aren't. And so we've been working on developing standards for those. And also there needs to be a lot of education for providers about what these blood tests mean, how to use them. So it's not simple. So
Yeah.
I can't really answer it in a sense, but basically, there's clear reasons to do these blood tests. You use them to help you determine whether a patient is likely to have Alzheimer's disease brain pathology or not. And there's all sorts of considerations. So a lot of education needs to be done.
Yeah, and I know from our first study on early detection, actually having systems at site of care choose tests often involves a lot of different components from primary care to specialty care, and people needing to align on what good looks like for test selection. So you've thought a lot about this. You've been, as you said, working through this for 3 years. What would be your advice to systems who are just sort of starting this journey in terms of the considerations when picking a test?
Well, I think that accuracy is really important because some studies have been done using blood tests in clinical populations and found that when you use poor quality blood tests, the results aren't very meaningful, which seems pretty intuitive, but we've seen a number of people do that because some of the lower quality tests are easier to access. So I think that as people are selecting tests, it's really important to get the best one. And we know that the p-tau 217 tests in particular are much more accurate than some of the other tests that are available. Fortunately, there's a number of head-to-head studies of these tests that are going to be coming out over the next year, and I think that those will be helpful as people think about which tests they should be using.
Right. And you mentioned so test selection, obviously very important. And then I think the next thing that a lot of systems or sites of care would think about, and you referenced a moment ago, is just education. So although the modality of taking blood is quite familiar to many physicians, the characteristics of these tests may be new. What, in your experience, both in thinking deeply about this and being an expert, but also in clinical practice, what are those really important topics of education that you've sort of noted over the last few years?
So there's a couple. So one is that a lot of people do not understand the difference between Alzheimer's disease and dementia because they're used kind of interchangeably by the lay public. So it's important to understand that dementia means that someone's had a decline in their memory and thinking that affects their function. And Alzheimer's disease refers to a specific brain disease that's characterized by amyloid plaques and tau tangles in the brain. And these blood tests are really designed to determine whether people have that Alzheimer's disease pathology in their brain. And there's lots of people who have dementia from other causes besides Alzheimer's disease. So you can be cognitively impaired, you can do poorly on cognitive assessments, and your Alzheimer's disease blood test can be negative. That's because your symptoms are not due to Alzheimer's disease, they're due to something else. But that's really important for people to understand. It's also important to understand that Alzheimer's disease really increases tremendously as people age, and that it's actually quite uncommon in younger patients. And so if you get blood test results in a 40-year-old with minimal symptoms, you should treat that very differently than, for example, in an 80-year-old with a typical syndrome of Alzheimer's disease. So it's not just the test result. It means it actually, your confidence in the result should vary depending on the characteristics of the patient. Again, this is why this requires some education of providers to interpret these tests correctly.
That's great. And as we're sort of talking about this, I noticed some questions in the chat that I think actually fit very nicely within the education topics that you just laid out. So, I mean, one from Redford in the UK, do you see blood tests being used for all patients presenting with MCI by their primary care practitioner?
I think that's possible. So one thing that's interesting is in our memory disorders clinic, it's standard of care to do a CBC, a CMP, B12, TSH. So these are routine blood tests. But really, it would be much more useful to do an Alzheimer's disease blood test. So for Alzheimer's disease pathology. So if someone had symptoms, mild cognitive impairment, some sort of symptoms concerning for Alzheimer's disease, it would make sense to me to do that kind of test. Again, you still need to do a thorough workup for all the other issues that can cause mild cognitive impairment, because often in our patients with Alzheimer's disease, we find that they have other things contributing that you can make better. But yes, I do think that there will come a point where we use these tests quite broadly.
Right. And switching gears a little bit, so I think it's been really helpful to talk about those education topics and sort of how should people think about, or the considerations to think about when selecting tools. We also know that from an infrastructure and operations point of view, to get these tests in primary care, it requires sort of a lot of moving pieces working in concert together, whether those be processes and systems or people. So what are some of the barriers or potential barriers you see that may hinder the implementation of blood biomarkers in routine care?
So one current issue is that a lot of the blood tests are not integrated into our electronic health records. And the way that a lot of healthcare works right now is you enter an order into the electronic health record system, and maybe you tell the patient to go to the lab, and then the blood's collected and sent to the appropriate lab, and then the lab sends back, ideally, the data, and it flows directly into the electronic health record. That doesn't really happen right now for a lot of the blood tests. So, for example, we just get the results faxed to us, and that makes things more difficult to not have that piece in the puzzle there. And then for things like digital cognitive assessments, some of these require things like iPads. We don't have iPads in our clinic and don't have a way to, we don't have a charging station. We don't have people designed to manage these. So these are all issues that are, we can definitely deal with these. It just takes some thought and some work to get these set up, and sometimes some money. In case of the electronic health record, some of the builds can be quite expensive.
Yeah, certainly. And, this resonates a lot with some of what we saw in our early detection study, where it seems like it could be a trivial thing, integration in a health record, but it meant for a system wanting to run the study, they needed to, sequester a staff member to manually input data into a health record. And given that many primary care practices are stretched financially, that obviously is a significant barrier. And then we would actually see in the data, just drops in clinics actually running these tests because a stylus went missing or there was a firmware update that, caused problems for the iPad. So, really, really in our data, we've seen what you're saying very, very strongly. It really matters. Maybe the final question related to this. So obviously, healthcare settings are going to vary pretty significantly, where you're going to have some health systems that have very integrated lab facilities, and someone might be able to walk down the hall and get a blood draw, whereas in other places, a dense urban area, they needed to take, public transit to find a lab and then sort of go back a number of times to site of care. What are some of the challenges we face in ensuring that tools are appropriate across different populations and settings that may have different resources, and populations may just be quite diverse in who they are and where they're coming from?
Yeah, so there's a lot of different aspects to that question. One issue is that we need to make sure that these tools work in different groups, in different populations. So you really have to do validation studies in diverse cohorts. So racially, ethnically diverse in terms of whether it's rural versus urban, and diverse in terms of medical issues. So a lot of these, for example, CSF tests have only been validated in highly educated white individuals. So we really need better validation cohorts. And then there's issues about infrastructure. So the infrastructure that you need in a specialty clinic may be quite different than what you need if you're out in a primary care setting in a rural area. So each clinic will have to sort of decide what they need. Hopefully we can come up with solutions that are transferable, that are shareable, but each of these settings is different, and what works well may be different in different settings.
Right. Um, and so I know we've got a few minutes left, so I think we've talked, about the promise of some of these tests, particularly blood, and making a pathway more scalable. We've talked about some of the challenges and complexity of just changing routine clinical practice. And I know that there are a lot of very dedicated, smart researchers and clinicians, you among them, who are thinking very deeply about this right now. Could you tell us about some of the global efforts we're seeing to bring stakeholders across industry research, advocacy, and policy together on these topics?
Absolutely. So there's a group, the Global CEO Initiative, that brought together quite a variety of groups, from academia to industry to patient advocacy groups, diagnostic groups, to talk about blood-based biomarkers. And we had several work streams. The first work stream was to set minimum performance standards for blood tests, and we just published a paper on that in Nature Reviews Neurology, describing the kind of performance you need for a clinically used Alzheimer's disease blood test in different settings. And then this group is also looking at other issues, like how can we streamline the patient care pathway? How do we educate groups about blood tests and Alzheimer's disease generally? So I think this is great, in part because it's bringing together so many diverse groups that are all thinking about the problem in different ways.
Right. And I think, wrapping up here, what to your audience would be the main takeaway or sort of call to action to move the blood biomarker field forward?
So I think over the next year, and definitely a year or two, there's going to be a tremendous number of studies published with many different blood tests. And hopefully at some point, some of these blood tests will become FDA approved. We are really just on the precipice of this becoming very available, and an accurate test becoming very available. So this is really exciting. I guess the call to action is education, 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 that we're going to have this tool, but a lot of people aren't going to know how to use it yet. So we're going to have to work with clinicians in particular to understand how to use these tests, how to interpret them appropriately, so that they can help patients get an earlier, more accurate diagnosis.
Right. Well, Suzanne, I really just want to thank you for joining us this morning and sharing your expertise for 20 minutes. It's hugely helpful. I know the audience appreciated it. We got a lot of questions, a few of which we were able to answer, and others that we'll follow up on. So appreciate you waking up very early to join us.
Thanks so much, and thanks for all of your work, Tim.
Thank you. Talk soon. So I'm very pleased to introduce our next session, Bridging Research to Practice for Accurate Diagnosis of ADRDs, and our moderator, Dr. Amy Deckert, who is an implementation scientist leading the Accurate Diagnosis program. We're really excited to talk about this program today. It builds very nicely on the learnings from our early detection flagship and grant programs, which we've covered in our previous meetings. You may have seen a press release for the new Accurate Diagnosis program from last week. Announcing the work, we'll make sure that we add that to the chat. And with that, Amy, let me turn it over to you to walk through that program and introduce some of the site leaders.
Great. Thanks, Tim. And thanks, Suzanne. That was really helpful context to set up the discussion today. So thanks all of you for being here today. As Tim mentioned, I'm quite thrilled to introduce you to the DAC Healthcare System Preparedness new initiative, the Accurate Diagnosis Program. So we'll start off with a brief overview of our program, and then we'll get into a discussion with 4 site leaders, and we're just so thrilled to have them joining us here today. So to start, let's take a look at the goal and the scope of the project and how it is we're going about it. So the objective of the Accurate Diagnosis Program is to identify effective strategies and the potential barriers of using innovative tools to support a more timely and accurate diagnosis of Alzheimer's disease. So in this project, sites are going to be using blood biomarkers and confirmatory tests. So these could be CSF through lumbar puncture or PET scans. And they'll be using these tools as part of their Alzheimer's diagnostic process. And this is so we can help prepare healthcare systems for using these kinds of innovations in regular practice. So it's a multi-site program. We launched in 8 sites across 5 countries. So Germany, Japan, the Netherlands, the UK, and we have 4 sites in the US. I'm quite delighted to have 4 of these site leaders on our panel today. And this way you'll be able to hear directly from them about the great work that they're doing in their centers. So all of the sites in the program have both primary and specialty care settings that have the capabilities to implement the Accurate Diagnosis Program. And we'll get into what those components are in just a moment. But I just wanted to note that we did intentionally select settings that are high in resources. And this is because we needed it to be feasible for these sites to implement blood biomarkers as part of their existing diagnostic processes for Alzheimer's disease. But please note that we do intend to bring these learnings to other health systems globally, and we'll do this using tools like the DAC Early Detection Blueprint. So in terms of what the program components are, we have blood biomarkers and CSF test kits, and these have been generously provided in kind by 4 partners from diagnostic companies. So a big thank you to C2N, Fuji Radio, Quanterix, and Roche Diagnostics for their support. Now, these partners will also support their sites with specialized training throughout the course of the project. Now, the sites are provided with funding, and this is so they're able to deploy the tests, collect data, and report on their progress and their outcomes. And then, of course, last, but I think certainly not least, perhaps the most unique or special feature of the Accurate Diagnosis Program is our community of practice. So this is where the sites will come together regularly and they share learnings and work together to solve common challenges that they're encountering throughout the course of the project. And it's through this community that these site leaders are going to collaborate on the next version of DAC's Early Detection Blueprint. And this is going to help ensure that other health systems around the world will be able to benefit from their learnings. So we are conducting a research study, and the objective here is to identify those barriers and facilitators to implementing these pathology assessments in the Alzheimer's disease diagnostic pathway. And this is in primary and in specialty care settings. So we have 2 research streams. The first is led by the sites. So this is where sites will be collecting patient-level data. So we will be able to identify the rates of biomarker use and the difference in the time that it takes for patients who've had a blood test and those who didn't in order to get to a diagnosis. And we'll also be able to examine the types of resources it takes healthcare systems and the estimated cost of implementing the program in primary and in specialty care. And at the same time, DAC is using methods and frameworks from implementation science to evaluate the program. And this is where we'll be able to identify some of those operational challenges, as well as the effective strategies or enablers across these diverse clinical settings. This is also where we'll be able to get an understanding of the factors that might influence uptake, scaling, and sustaining biomarker use in primary and in specialty care settings. Now, with that, I'd love to turn it over now and introduce you to 4 of our 8 site leads who are joining us on this initiative. So we'll start off with some introductions. And perhaps you can just tell the audience a little bit about yourselves, your role, and a bit about your organization and the people that you serve in your healthcare system. Michelle, can we start with you?
Sorry, on mute. Hi, I'm Michelle Milkey. I'm at Wake Forest University School of Medicine. And my co-PI and partner in crime for this project is Jeff Williamson, who's a geriatrician. And so our focus is really on primary care patients, particularly internal medicine and family medicine, in the Greensboro and High Point area in North Carolina. So we're focusing in roughly that area. We're expecting about 30% underrepresented minorities, and also a wide swath across the socioeconomic status spectrum.
Thanks, Michelle. Atsushi, how about you?
Hi, my name is Atsushi Iwata, Vice President of Tokyo Metropolitan Institute for Geriatrics and Gerontology, and it's located semi-suburb of Tokyo. I'm a neurologist by training, involved in Alzheimer's disease drug development for more than 15 years, maybe. And in our country, Leqembi is around for almost half a year already, and the number of patients taking Leqembi has reached 1,200 so far. And our institute have the 40, the largest number of patients countrywide. And the large portion of the patients coming having Leqembi was referred from local PCPs, including any local PCP around Tokyo. So I think this project will be really helpful for our community. Really excited to be here. Thank you.
Excellent. Thanks, Atsushi. Jeff, over to you.
Yeah, hi. So I'm Jeff Burns. I'm a neurologist, and I co-direct a large research program and also direct our memory clinic, which serves Kansas City. I'm in Kansas City, University of Kansas Medical Center. And so Kansas City is a large metropolitan area, about 2 million, and then surrounded by very large rural spaces. And so our challenge is how do we first support Kansas City? We're really the only memory clinic in the city, but also how do we support that rural Kansas and rural Missouri, which we border. So we have a lot of challenges, and we're excited about these new diagnostics.
Excellent. Lefkos.
Hi, thanks for inviting me here. I'm Lefkos Middleton, Imperial College London. We have 3 affiliated hospitals spanning St. London with St. Mary's and North, and extending into rural areas, beyond the Greater London area. The metropolitan population we cover is around 2.5 million. And what I would like to emphasize here is the specific features of the national health system in the UK, which is very primary care centric. So primary care physicians or general practitioners, they really hold the key to the health of practically all of the citizens in this country. Even if you have a private insurance, you must be referred to a private doctor or a private service from your GP. So the main challenge that we will have is how busy and overwhelmed primary care practices are in this country. And up to now, the sort of care pathway was a little bit like the rest of the world, rather stagnant, with the primary care physicians doing some basic blood tests, and if they had fears of or concerns of possible cognitive decline, patients would be referred and are still referred to memory clinics of mental health hospitals without any sort of biomarker or imaging capabilities. So like actually in other parts of the world, reaching a specialist unit can take months. I think these are the sort of issues that we hope to be able to address, quantify, and qualify through the DAC study.
Great, thanks, Lefkos. Thank you all of you for the introductions. maybe to get the conversation going, why don't you tell us a little bit about why you were excited to be a part of the Accurate Diagnosis program, and maybe what drew you to be wanting to be involved in the first place? Jeff, can we start with you?
Yes. So yeah, great. Yeah. So I'm very excited. I mentioned earlier that, excited about these new diagnostics, and we have these huge challenges, which we've been hearing about, where we don't have enough neurologists, we don't have enough specialists to support the patients that are out there. Now we're turning patients away. We can only see about a third of the patients that are referred to us as really the only memory clinic in Kansas City. And that's a huge problem. So we have these new diagnostics arriving, we have new drugs arriving. So it's really an incredibly hopeful time, but we have to figure out how to meet this need. And it's not just going to be doubling or tripling the size of our memory clinic. And I think we know that we have to come up with ways to get primary care. Primary care is already treating many patients, but we have to come up with ways to optimize the care they provide and increase the confidence and the accuracy of their diagnoses, and then create the support systems to support them in a more focused way. And so I'm excited because being a part of this DAC project allows us to get a head start on that and to really, work to figure out how do we leverage these new diagnostics, how do we work better with primary care and establish the network the network that we've built, and actually, build on that and really drive these high impact efforts forward.
Thank you. Atsushi, what is it that you're excited about?
Yes. So in our country, every patient is covered by the universal healthcare system, and which is kind of really cheap among all the countries, I guess. And the result will be that the patient will visit specialists at the first visit, so they don't have to go through any PCP system to visit, dementia specialists. And what happens is that if they don't, the dementia specialist is a appointment is full, they want to go to PCP. So PCP has to take care of biomarkers and MRIs and everything. That would happen, and that happens already. And what happens after that is that the education is very important for those PCPs. And as Suzanne told us, PCPs probably more than half of them don't recognize the difference between dementia and Alzheimer's disease. But still, they want to incorporate new technologies like MRIs or even blood-based biomarkers. So what I'm kind of worried about is that, doctors who doesn't understand the difference of dementia and Alzheimer's disease might use blood-based biomarkers. So we have to incorporate those technology properly into our society. So by using this DAC project, I want to make some sort of a test case for those, learning PCPs, teaching, specialists kind of settings. That's what I'm thinking about with this project. Thank you.
Great, thank you. Michelle, how about you?
Yeah, thanks. I think both Jeff and Atsushi brought up some very important points, and we're aligned with that as well. Another reason that we were particularly interested in being part of the DAC project was just the community. So as Dr. Schindler had mentioned earlier, each place is a little bit different. There are some different workflows, but in the meetings we've already had, there are common problems across the different institutions. And, there's a lot of things that you don't think of when you're getting started in terms of implementation that kind of come up, even, getting CPT codes in the records, getting couriers, education, how best to do that, when, how to take burden off of primary care. And so we're already learning a lot from the other sites and getting a lot of good feedback on the work we're doing. And that's been really helpful.
Great, that's excellent. Left Coast, how about you? Is there anything you want to add?
Well, I fully agree with everything that has been said and share the incentives of my colleagues, but I would like to add one point. It's all about timing. So, since the years of Molière, when he said that the role of the doctor is to hold the patient's hand, waiting for nature and God to take care of their health. In the last 50 years, we've seen tremendous developments in many different fields of medicine. And the most recent ones, of course, have been HIV and cancer over the last 15, 20 years. Our field is going through a true paradigm shift with the recent FDA approvals of disease-modifying therapies. And I think this wonderful new development of blood-based biomarkers that practically democratize the diagnostic and care pathway across the world, not necessarily in small areas surrounding highly specialized centers. So the next 5 years will be quite significant for the future of our patients and for the future of prevention. And I'm delighted to be part of the DAC program and look at the issues and, like I've said, evaluate challenges, opportunities, and try to mitigate all of the difficulties that we will be facing. The one point I would also like to add is practically an ethical issue. So even when a BBM is going to be requested for a patient, a consent form needs to be signed, and there needs to be explicit information provided what exactly the test will be and what the results will mean. So I'm just repeating what Suzanne and others have emphasized, which is the need to educate the healthcare professionals at the primary care level so that they can manage all of this information in an informed and clinically relevant approach.
Great, thank you. I think that really highlights a point we've been hearing a lot about in our community of practice, about education. And Michelle, you alluded to this. It's been quite exciting, I think, for the DAC team to see the community sort of evolving and all of the sharing and learning that you've been doing together. I'm wondering if each of you could share one thing that you're hoping that the community of practice will be able to contribute, or what you're hoping to gain from being a part of that. Atsushi, why don't you start?
Me?
Sure.
Well, yeah, so what to say? Well, so I had this several cases that there have been knowledge about dementia for PCPs, so they want to diagnose dementia or even MCIs. And what happens is that they know the knowledge, like logopenic aphasia or primary progressive aphasia or like posterior cortical atrophy. But the thing is that they cannot diagnose the actual patient. They know the knowledge, they know what those diseases are, and they know how to, how those patients will present, but still they cannot diagnose the patient because they don't have any skills. So what they try to do is that try to stick to biomarkers or imaging technologies, and which is good if they had skills, but if they don't have enough skills for those diagnostic procedures, that will be a mess. And I wanted to have improvement in that kind of environment.
Thank you. Jeff, is there anything key that you're hoping to gain from the community of practice?
Well, I mean, I just think it's a great opportunity to kind of see how everyone's approaching this, and everyone's approaching it in slightly different ways and with key learnings, and so that's a huge opportunity to share. What are the barriers for one site versus others, and how are they overcoming them? And I guess I would say I'm probably most interested and excited about seeing how the education pieces and how the various sites are working to develop support for primary care docs who are using these tools, who begin using these tools and diagnosing more patients. Then what? How do we support them? And there's a comment in the Q&A about decision support tools being built in lab result forms, or one of the things we're working on is decision support being built in cognitive screening pathways that we're trying to create in the electronic medical record that then link with the labs. And so it's those kinds of solutions and or actually identifying the barriers is helpful. Where are people struggling? And then how are they dealing with the trying to solve and overcome those barriers? So lots of learnings, but my focus would be on those education and support tools that we're creating for primary care.
Lefkos, anything key for you?
Well, I think it has been said, it's this is a tremendous opportunity. At the time that we will be introducing these new approaches to, at the same time, understand challenges, opportunities, and I think being part of this wider international community definitely will allow us to share experiences, approaches, methodologies, both in terms of educational programs and also more technical issues. I have to say that we've been having quite a positive experience with our technical partners in the process, with quite an intense exchange of ideas, documents, even on the front of educational programs to primary care. So the benefits are already starting to show.
Great. Michelle, I know you started this discussion, but is there anything you wanted to add about the community of practice?
Yeah, I think everybody gave some really great examples, and completely on board. Maybe just for the audience, a couple of our discussions. I think most of one meeting was talking about the blood biomarker results. So are they being put in the medical records? How are you disclosing them? Technically with DAC, it's still research, and so it doesn't necessarily have to go in the medical records, but down the road, it will have to. And so how do you disclose this? Does the primary care physician do that? Does maybe an APP do that? And so just kind of thinking through that. And, again, as we do go along, we'll learn from others in terms of best practices.
Great. Thank you. There's been so much synergy so far. It's been really exciting to see that happen. I guess I'm just curious to know, why do you think it's so important that your clinics are using these innovative kind of tools like blood biomarkers? And what kind of challenges are you expecting more at your healthcare system level? Anyone want to start?
Where to start? I think, at least in the case of the United Kingdom, the healthcare system needs to adapt to this new reality. And the current care pathways need to change. And there needs to be significant investment, new resources, developing and educating and developing primary care to be able to optimize the use of these amazing new tools for early and accurate diagnosis, and also reinforce the number of specialist centers across the country that may be able to kind of take things to the next step in terms of what we now do. I mean, what treatments are available, which trials are available, and how to take care of the next step once an initial diagnosis is made.
Michelle, do you want to add to that?
Yeah, so I think some of the newest diagnostics for cognitive testing and also blood-based biomarkers, I think really will help to improve earlier diagnosis of Alzheimer's disease. But there are, various barriers in terms of reimbursement. So with primary care, if it's not reimbursable, it's not going to be done. And also the challenge of, primary care already so busy, seeing so many patients a day, trying to incorporate the new diagnostic pathway without totally overburdening the system either. because if it is overly burdensome, then it's not going to happen as well. So really, how can we do this best for both the providers and the patients?
Thanks. Atsushi?
Well, as you may know, we are one of the oldest society in the whole world. And the problem is that, the candidates for like say Leqembi or maybe donanemab is over 1 million people. And our healthcare system is so universal. We're supposed to equally provide, the drug to all of the candidates if they are eligible enough. So by using like CSF or PET, well, it's okay when, it's precise diagnostics, but still, the cost is so high for at least for like PET, and it's not efficient enough to provide to like over 1 million candidates. So for blood-based biomarker would serve as a very convenient technology to facilitate incorporation of anti-A-beta or maybe, some more advanced drugs for the candidates. But still, our knowledge is not enough for incorporating the proper knowledge to our society. So I think that will be the challenge for us.
I'll just build on that a little more. Yeah, I mean, we're dealing with this challenge of how do we scale up to support the treatment with these new drugs like Leqembi of all the patients who are eligible and want the drug, and that's a huge challenge. And so I think one of the promises of these new diagnostics is they can help us do that by sort of bringing in the primary care world closer to the specialists and get that diagnosis made confidently and accurately at the primary care level, so that we can then more efficiently use or develop treatment approaches, treatment clinics that can support that huge challenge of how do we treat the patients who deserve these new drugs. And we're of course very hopeful that these new drugs are just the start and that there's a lot more coming. And so all of this hopefully sets up a future where we're able to better diagnose efficiently and accurately in primary care and better support the needs of those patients with specialists that are too few and far between, but through more efficient delivery and new models of care.
Great, thanks everyone. We did have a question in the chat, and I think Michelle and Tim have already started to answer, but if the other panelists wanted to comment, it's what kind of supports are you putting into place for patients who are going through the diagnosis process? And just commenting here that it can be quite scary. Anyone wanted to add?
A huge priority.
Yeah, I agree. I mean, that's a good example of this isn't just a simple, we drop this new lab test in the middle of the health system. We've got to think about all these things, support for primary care, but also support for the patients. And how do we support primary care docs to give this kind of support, that's being brought up, caregiver support, patient support. So yeah, huge challenge, and we need new systems, and we need to continue to push forward that kind of support.
Particularly, I think, with reimbursement models, because again, if it's not reimbursed, it's going to be very hard to incorporate. But if you look at the cancer field, they have navigators and whatnot that can help along the pathway, and we need the same thing for Alzheimer's disease and dementia.
You want to talk a little bit more about those navigators? And there's also a question in the chat about those.
Sure. So we're incorporating what we call brain health navigators, which right now are advanced practice providers, so physician assistants or nurse practitioners, and to really be the go-between between primary care and the patient. So essentially, if somebody's identified as high risk, basically that they'll be referred, the APP will contact them, help them schedule for a cognitive test if they're interested, kind of guide them along the pathway, and also identify some potential interventions as well down the road, because only a small subset will really be eligible for one of the disease modifying therapies. But you can't just diagnose somebody and then be, sorry. And so it's really identifying those avenues. Maybe they need to treat vascular risk factors. Maybe they have insomnia, and that's affecting their cognition as well. So really helping them down the whole pathway.
Great. We have a follow-up question from Krista as well in the Q&A, asking if there's any close ties to patient advocacy groups that might be able to help provide some of those supports. Do any of you have anything to comment about that?
Well, we are already working on that front at our site, both in terms of advocacy groups for related to dementia, but also related to different ethnic and other groups within the community. And one of the PIs of the study actually has as a primary objective to develop a strategy to engage community-based groups and advocacy groups, and in particular, like I said, West London has a significant ethnic diversity among its population. So we are putting a lot of emphasis on that, and also on groups that would support patients with dementia.
I'll just throw in a real quick comment. We on this, the Care Navigator idea, our approach is we've created a team of social workers and nurses who support patients when they're and families when they receive a diagnosis from primary care docs or in our memory clinic, and provides that kind of navigation support that we're talking about. And it's so important, and it is hard to fund. There's a question about funding, and we fund it through philanthropy right now. I think there's, Medicare's new guide program offers potentially funding for this kind of approach in the future. So I think that is a nice, innovative, new care model that's coming to help. But we need more, more than philanthropy and partnerships like that. So, but it's such an important piece, and it's actually not just important; it's essential. So push forward on all those ideas.
Great. Atsushi, is there anything in Japan where you have support for the patients through advocacy groups or otherwise?
Yeah, that's a very good question. So I'm afraid to say that in our country, advocacy or family, group is not functioning so well. So I don't know why, but maybe it's our fault. Maybe it's something else. But we definitely have to develop that kind of help in the near future. Thank you.
Okay, so we're in the last 5 minutes or so of our discussion, and I just want to thank you. And first, I'm hoping that you can all comment on your long-term plans for scaling the Accurate Diagnosis Program across your health systems and sustaining what you're doing and what you're setting into place today. Left Coast, do you want to get started?
Well, of course, this is a first step. I'm very encouraged to see that in this country, NHS is already kind of looking at all of this in a very strategic manner. And it seems that they're taking these new developments very seriously and thoughtfully. And I can see that the strategy is being built, so that lessons learned from our DAC study in London and at the other sites would, I think, inform the strategy being developed by NHS significantly.
I'll give my sort of vision for the future, at least locally here in Kansas City. It's work with our 100+ primary care docs in our health system here to develop, an approach where it's not just our 4 or 5 memory docs treating these patients. It's the 100+ primary care docs working, strategically and in a focused way with our specialist support, to provide the care, the diagnosis and the care to the patients across the whole health system. We solve that. We have our network that I briefly mentioned, our cognitive care network of primary care docs across the region and the state. We can move those practices into that larger network across rural areas. And so I think it's going to be new models of care and then networks of care that we develop that helps move us in a positive direction where we're meeting these challenges.
I'll hop on next. So Wake Forest is the academic home for Advocate Health, which has resulted in the last couple of years with several mergers. And so we now cover 4 states in the Southeast, North Carolina, South Carolina, Georgia, Alabama, and then 2 states in the Midwest, Illinois and Wisconsin. So we've got about a 6 million patient population. Our leaders are really attuned to the burden of Alzheimer's disease and the need to develop better patient care pathways. So, I mean, really what we're learning is to set us up then to take this across the entire health system in the coming years.
Thanks. Atsushi?
Yes. So I'm living in Tokyo, which is one of the largest cities in the whole world. Consists of maybe more than 14 million people in the entire city, and all the suburban area consists of maybe 20 million people. And in Tokyo, there's more than 50 cities, and I'm in one of the cities. And I'm collaborating with the city doctors society from the beginning. And I'm trying to expand it to the neighboring cities and have some collaboration with those people to have enough education for at least in my local part. And then we are thinking about using government funding, beyond to expand this effort to decentralize our efforts by using digital technology or maybe digital biomarkers to extend our knowledge into the entire country. That's my entire vision for maybe the next 10 years.
Wonderful. Well, thank you so much to all of you. It was such a thoughtful discussion. And I think most of all, I want to thank you for collaborating with us on this initiative. It's just been such a pleasure to work with all of you so far, and I'm looking forward to the great work we've got ahead of us. And thanks for joining us today to share about your experiences for this learning lab. And that's it. So now I'd like to pass the torch over. We'll welcome the DAC chairman and founder, George Vredenberg, and he's going to lead us in the final discussion for today's meeting. Thanks, everyone.
Thank you, Amy, and thank you panelists for a really fascinating discussion about the challenges confronted by even large and well-financed health systems in dealing with the rush of new patients with potential Alzheimer's or other dementias, and the difficulty of integrating new tools into those systems. A critical part of why DAC was founded was the belief that since most of the people, 2/3 to 3/4 of the people with Alzheimer's or other dementias in the world are in low and middle income countries, and obviously in low resource settings, even in high resource countries, that we needed to understand how best to address the challenges confronted by the Alzheimer's and other dementia populations around the world, and thus how it is that we can learn across these resource settings. So obviously, it's possible for us to learn a good deal about how to integrate blood-based biomarkers into health systems in high-resource countries, Europe, the United States, and Japan, as we've just heard. But how can we take the learnings from high-resource countries and imply or apply them in low-resource settings? And alternatively, how can countries that are not burdened by the legacy systems of high-resource countries, low and middle income countries, be innovators in this space, because they have to deal with lower cost settings and have to figure out new ways of doing healthcare for Alzheimer's and other dementias in lower resource contexts where innovation and low cost approaches are even more essential than they are in high resource settings. So I'm really pleased to facilitate this final dialogue of today on the horizons, the challenges and opportunities for global implementation, and to invite our speakers, Karen Blackman and Ishtar Govia to join me. Ishtar, thank you for joining us, and I look forward to Karen Blackman joining us there she is. So first, let's do some introductions. Let me ask each of you to introduce yourself. Ishtar, if you could give us a brief introduction of yourself and tell us about your efforts in Jamaica, and Karen, your efforts in Kenya to deal with this early detection and diagnosis of people with Alzheimer's or other dementias.
Thanks, George. Yes, I'm really happy to be here and to be sharing this time with both you, George, and you, Karen, because I know we've all been doing some important work in this area. I'm trained as a psychologist. I'm an academic with expertise in implementation science and mixed methods. And I was able to leverage that expertise and that academic background for the work with the Davos Alzheimer's Collaborative Early Detection Project. And just to be clear, that was an initiative that was focused on a patient pathway where we were implementing digital cognitive assessments. And the idea was to also implement blood-based biomarkers sequentially in primary care. And to do that, in the prototype setting was really modeled on the US, where there's an annual wellness visit, and we can get into some of these specific details. So I've recently transitioned out of academia into a founder role of my own startup, which is focused on addressing this treatment gap in brain health and dementia, given some of the challenges that I've seen working in academia as well as working through non-governmental organizations. And I'll hand it over to Karen so that she can introduce herself.
Thank you, Ishtar. Thank you, George. This is really a pleasure to be here. I love these learning labs, and I'm happy to be a part of this global cohorts program, which I think will ultimately have a huge impact on addressing disparities in diagnosis and post-diagnostic care. So I'm a clinical neuropsychologist in training, and I'm at Aga Khan University in Kenya, Nairobi, Kenya, with the Brain and Mind Institute. And I'm the principal investigator along with Chi Udemomo. And we are working on a study funded by DAC to validate a suite of fluid-based biomarkers and cognitive tests, both digital and traditional paper and pencil-based cognitive tests, against what we think is, true dementia signal. And what I mean by that is at Aga Khan, it's a relatively well-resourced setting within a limited resource country. So in Nairobi, there are a few universities and hospitals that have relatively more resources, and Aga Khan is one of them. We have FDG PET, we have lumbar puncture cerebral spinal fluid diagnostics, we have SPECT scanning, and we have 3 neurologists and 2 neuroradiologists. So what that means is we can be fairly sure, more so than in other settings across Africa, that what we're seeing is Alzheimer's. So, right, it's all about probability, but the probability is higher with better diagnostics. So we use that and leverage that to validate tools that are more accessible to the broader population in Africa. So we think critically about the cost of those tools, because we know that, of course, FDG PET and SPECT scanning is a bit more expensive. So if we can validate lower cost tools against true dementia signal, then we can feel more confident that when we scale up those tools in a broader region, that they're doing what they're supposed to be doing, which is detecting dementia. So I work with a very talented team of personnel from Kenya who've already been part of the clinical health systems and help us understand the value of our tools as we are adapting them, both for language and the methodology that we use has to be acceptable by communities. So we do a lot of work around what we call the living lab approach. We work with community stakeholders, community advisory boards to make sure whatever tools we are investing in to get confirmation or to be able to determine the diagnostic accuracy, that we have thought critically about the end from the beginning and whether they'll be acceptable to the communities that we serve.
Let me ask at the outset whether you're developing these tools, starting with you, Karen, and then moving to Ishtar, in a research setting or in actual clinical practice? And what are the capacity or resource or other constraints in actually moving these tools into clinical practice?
So it's technically a research setting because it's funded by DAC, right? So it's a research study, but it is being conducted in the context of a clinical environment. So I would say, although it's research, we have a clear eye on how we will integrate our findings into the health system. And that's always in our mind. It's where we hire personnel to the tools that we choose. There's no point in validating tools that won't be accessible down the road in the clinical health system. So yes, it's research, but definitely with an eye on clinical application.
And when you talk about tools, you're talking about blood-based markers and digital cognitive assessments, or are there other even lower cost tools than those that you're experimenting with or valid?
So, yes, primarily fluid-based, and that's blood and saliva. We're focusing on mostly. We also have other, tissue that we're considering, or even hair samples and urine samples, but primarily fluid-based biomarkers and cognitive tests. And we're looking at digital cognitive tests, but we also want to think about more traditional tests, and in part because that links us to a lot of other global efforts to improve dementia diagnosis. So we're not existing in a vacuum. As a research environment, we know that there's a lot of other research initiatives, and we want to be able to compare across those. So we do integrate some of the paper-based tests that are being done in other large-scale efforts, but with the novel clinic or the digital cognitive tests that are a bit more at the cutting edge of where neuropsychology, at least, or neuropsychological assessment is going.
Ishtar, let me modify the question slightly. You've sat in on the discussion of the high resource country settings that we just had from 4 different environments: the UK, the US, and Japan. Is there anything that you're learning from that conversation that's applicable in the low resource settings that you traditionally have been dealing with? And I know you now have a role with the WHO. How are we looking at these kinds of developments in the high resource countries for their applicability in low resource countries, or are low resource settings saying we have to do things different or differently than the high resource settings because we're a low resource setting?
Well, I think one of the big examples of that for us in Jamaica was looking at the initial patient care pathway that was provided to us, which saw, as I suggested at the beginning, this annual wellness exam as the first touch point. Jamaica was one of the 3 private healthcare systems that were engaged for the early detection program. The other 4 sites, health systems and countries, were public healthcare systems. And what we saw with the Jamaica sample, we collected data from over 740 participants. And we saw that the vast majority of those participants, over 85%, screened as cognitively impaired or borderline for cognitive impairment. And that's really startling. But when you think about the actual way in which we had to recruit patients, that's very telling in terms of the differences between the low resource context and the high resource context. Because in our context, we went to primary care practices, and we also used community-based events, health fairs. We worked in partnership with places of worship, for example. And what you find in those contexts is that persons who are 60 and older, they go to these events, they go to their primary care physician when something is wrong, when they have a concern. And they may not know what that concern is. And through the process of actually participating in this, one of the key learnings for us that is transferable to high income countries, to high resource contexts, it's common and consistent, and the speakers on the other panel have alluded to this as well, is that using the digital cognitive assessments, using any type of memory or cognition screening device is not a one and done type of approach. That what that does, in essence, is it opens a whole plethora of issues that need further investigation, that require multiple touch points with each patient. And what we saw with the early detection program in Jamaica was that the digital cognitive assessment allowed us to then say, these are the participants who are eligible for these tests for reversible causes for cognitive impairment. And in Jamaica, while we did not actually do the blood-based biomarkers because our systems were not set with the efficiency that we needed for the agility that the DAC grant program, the funding program required, and the time frame that it required in terms of ethics, in terms of export license, and all of those types of things, because we would have needed to ship the samples to the United States as they could not be processed in Jamaica. Even though that was not able to happen with the Jamaica site, what we did have, which I don't think any of the other sites had, was we had fully subsidized for those patients who met criteria, tests for exclusion for these reversible causes. And then what that did was that it revealed to the patients, as well as to the primary care physicians, who were not, even though this patient was coming to them, they were not actually investigating for some of these concerns. And those tests actually revealed dyslipidemia, the high cholesterol, all of the pre-diabetes, all of these concerns that were actually fundamental to thinking about appropriate patient management, even something like hearing impairment, because we had a number of patients who had impacted wax, and so in their ears, and so they couldn't really facilitate appropriate types of treatment unless those things were discovered. And so in terms of understanding what needed to happen next in terms of the after diagnosis, that screening is not just screening and then it's done. We found there's a lot of drop off if there's a huge amount of time between when the screening is done and when these tests for reversible causes are done. So it's really important to hold the patient in the system and in the service and provide continuity of care. And I think that's very transferable regardless of the context.
That's fascinating, because you're basically saying some of this can be driven by addressing the reversible causes of decline,
Definitely.
rather than thinking that you have to have a medicine. Because
Exactly.
in resource countries, at least in the United States, Japan, and China, we have approval of disease-modifying drugs, and that seems to be catalyzing in the health systems the need to begin to address how to detect and diagnose the people that might be appropriate for that product. It's going to be a very long time before we have these disease-modifying drugs available in low resource settings. They're too expensive. They're hard to diagnose for. But you're describing a different kind of motivation for earlier detection and diagnosis by diagnosing the things that aren't Alzheimer's.
Yes.
Things are not dementia, but they are reversible causes. So
and it's not either or, George. And I know Karen probably has experiences with this too, because it's not just diagnosing dementia or something else, because you realize how interactive we're human beings, and you generally have more than one condition that you're managing. And so that's really important to consider as well.
So Karen, to what extent are the efforts to adjust the community health or the more general health system in Kenya going to be affected by the availability of a drug that is much more accessible, lower cost than our current monoclonal antibodies? I mean, to what extent do we need a treatment that is going to stimulate people's and health systems' desire to detect whether they have Alzheimer's or not?
Well, the treatment has to be for the right disease. And I feel like we're still not even there yet of knowing if what we're seeing is actually Alzheimer's disease. And I think, Ishtar, you made an important point about those high rates of low scores on the measures typically used to diagnose dementia. And that's been something across the board we've seen in Africa for many years, is the tests aren't so great, at least cognitive testing. And for many reasons, there's just an inflation of dementia rates. Of course, limited education and the multidimensional effects of poverty are a large driver of that. And it's not always because poverty leads to, let's say, risk factors for dementia. Sometimes it's as simple as someone who's poor may not have gone to school and may never have seen a clock. And so you can't ask someone to draw a clock if they've never seen a clock. Or if they aren't even used to drawing tests. Like, we use drawing test as a way of getting around culture. But the truth is, if you haven't been to school, you've never sat with a pencil and learned to think about space in a 2D manner that you would need for drawing. So our tests themselves are just, really suboptimal for getting at the brain system that could be going awry in the context of Alzheimer's. So we are starting at that point of not just trusting that tools that were developed in very different times and settings, and we want to make sure that the tools we're using are actually fair for people who don't have much education or come from limited resource backgrounds. And so then once we can determine what's true Alzheimer's, then we know the rate of the problem, because we're still not sure about that yet. And then when it comes to treatment, we're not sure about the cultural acceptability. In the US and other places, there have been treatments for things for very long periods of time. People are used to considering the pros and cons of different treatments in close collaboration with their doctors in a long relationship. So there's a lot that needs to happen to even create that context where we know it's the true Alzheimer's disease, the person trusts the doctor, is willing to try something very new to treat it. So while we're investigating all of these pathways with eventual, that lead to disease-modifying treatment, there's also value in thinking about other treatments that could be address maybe different related problems to dementia, not Alzheimer's, but how to keep the brain stimulated, how to keep people physically active, how to keep families engaged with patients, and not to say, okay, well, they're declining and now we don't know what to do with them, but to keep their lives active and healthy. So there's all sorts of things we can be doing besides creating a path towards disease-modifying treatments.
Well, sort of last question. I'd ask what might be done, if anything, at the policy level, at a government level, that basically would encourage the more rapid adoption or the greater awareness of the need for more rapid adoption of these lower cost tools for detection and diagnosis. The UK at one point set a diagnosis rate goal for the UK, right? That's one thing that could be done. Another could be screening for cardiometabolic conditions, to Ishtar's point about this is one body. Can we address things that are available with treatments for cardiometabolic conditions that might have the future impact of reducing the prevalence of dementia? So is there anything that we can do at a policy level, whether Ishtar at the WHO or Karen at a country level, that could accelerate some of these efforts? Ishtar, why don't you start?
Sure, I'll start. And what I would like to say is this is not the formal opinion of the WHO when I'm speaking. Please do keep that in mind. But at the governmental level, it would be really important to think through how we can incorporate and incentivize the embedding of some of these other indicators that we need in terms of the diagnosis into administrative data collection and routine care. That sometimes could require things like, again, upskilling of health and allied practitioners, and even the data collecting infrastructure in the country, because that means that people need to understand how do you actually complete a death certificate when there is a potential Alzheimer's disease or related dementia as a cause of death. So appropriate training and funding for appropriate training for workforce, and that's health, but also data and data capturing, integrating the assessment of routine cognitive indicators into data collections, and that's both electronic health record system and mandating that from health providers as well is another opportunity. Countries really do need to be participating in WHO's Global Dementia Observatory and providing their data to the WHO so that the WHO can be monitoring these things. And then there are other things that governments can be doing, which are to conduct health economic studies. So looking at what's the current cost, the current burden and associated costs, and that's not just of the disease itself, but thinking about direct care and indirect types of care costs. And then also building out funding to build out services that don't exist, and then working with other players in that multilateral donor space, and really trying to build out these types of funding mechanisms, working in partnership with other governments.
Karen?
I agree with everything that Ishtar just said. That was a very comprehensive answer. So yes, that is, it's all the same things apply in Kenya. So I'd say, basic coverage for these screenings is essential for screenings for diabetes, for hypertension. Will probably have high yield, but at the end of the day, it comes down to a stigma, and stigma comes from not understanding the problem. So by doing science and educating the public about what the issues are and understanding that dementia as a disease, then there's a demand for attention to this. So once we create anti-stigma campaigns, dementia awareness campaigns, then the public demands attention to this from the governments. So we can educate the governments, but we have to also educate the public, and they have to want to use these services and want to go and get annual screenings and care about their brain health. So that's why we do a lot of community engagement sensitization work as well.
Yeah.
Well, it's terrific. Well, thank you both very much for what you do every day of the year. But thank you for joining us today and offering your insights and observations and your experience to this wider group of people that so committed to trying to change the world as we enter into what Lefkos has described as this new world where, in fact, we have to begin to deal with the brain in ways that we've never really actually had to deal with it before. So I think what you're doing is amazing, and appreciate your efforts, and appreciate how you are going to both inform and the rest of the world, as well as the low and middle income country settings, but to inform the higher resource settings of what can be done and why it should be done, even now, even absent medicine, to actually deal with the issues that are causing dementia underneath this. So thank you very much for being here today, and appreciate it. Thank you.
Thank you, George.
Have a great day. So let me
Thank you.
just last few minutes of our session here today, just to say that the Davos Alzheimer's Collaborative, as I said earlier, is really seeking to bring together low and high resource settings to deal with the issue of the need for health system transformation in light of the growing problem and prevalence of Alzheimer's and other dementias around the world, and to deal with the prospect that, in fact, brain resilience and brain power is going to be such a critical asset for countries and peoples around the world, so that we deal not just with dealing with brain disorders, but we deal with building brain power and brain resilience for societies as we move into a much more highly technical world where brain power is going to be so essential. Cognitive training tools being a potential intervention that could, in fact, increase our brain resilience. I'd ask everyone who is on this call to think through how they can contribute to this effort to learn how better to have our health systems deal with this tremendous global problem of Alzheimer's and other dementias. And if you do have continuing questions or comments, or offers to help in some form or fashion, please get in touch with us. Obviously, we have a Davos Alzheimer's Collaborative website is one mechanism, and the invitation that you got from the Davos Alzheimer's Collaborative to participate today is another way to get in touch with us. But this is going to be a team effort around the world on how to address these issues. And we need everyone's participation, high and low resource settings, academics, industry, patients, and the like. So I deeply appreciate everyone's attendance today, everyone's willingness to learn and to teach us. So all of us are both learners and teachers at the same time. Have a great day. Thank you for attending.